Welcome friends, students and colleagues. This is Dr. Jaitly from New York, your cardiologist on MuniMeterHealth, your source of learning, medical education and of course patient education, both together. So we have an audience, a wide audience of medical community and patient community as general, and of course we are improving the clinical outcomes, hopefully based on narrowing the difference between the medical education and the patient education, as you see. So welcome again on these short videos where we have a diagnostic criteria today for heart failure. Clinical, obviously, the clinical heart failure. So heart failure is basically a clinical syndrome where the heart function is not able to meet the needs of the body, and that is in general a broad definition of heart failure. So when the heart fails to meet the functions of the body or the demands of the body, that's how. So the oxygen, remember, every single cell of your body requires oxygen delivery, and heart, if it fails to deliver oxygen to every single cell optimally, that's considered as heart failure. So it is a syndrome. So again, it has lots of reasons, and we have discussed the causes and the types of heart failure in different other videos. Today we're just going to briefly talk about what are the major criteria and the minor criteria for diagnosis of heart failure. Now, one of the things that commonly immediately comes to your mind is patient will have tachycardia. So the heart rate is definitely increased. It's sometimes more than 120. You may end up seeing patients with atrial fibrillation, sometimes SVT. So there might be arrhythmias as well. Other issues like JVD, which is jugular venous distension, or neck veins may be more prominent, and sometimes you may see that the pressures could be anywhere more than 15 centimeters of water. Normally it's reported as water, so that's how it's maybe seen, and you have to see them in a 45-degree angle, compare it, measure from the angle of Lewis, which is at the sternum, and go up to the neck and see exactly vertically how high the jugular venous distension or the pulsatile flow in the neck veins and the jugular veins is. Patients may have S3 gallops and then will have rales at the bases of the lungs. And why? We'll show that in a second here in an X-ray form, if you like. Let's go to the right side of the panel here, and you'll see my schematic of an X-ray, if you will. We are showing the lungs on either side, and we are showing the heart in the center, if you will. And here comes the aorta, which is an offshoot, the major vessel which is supplying the rest of the body. So the curly B lines, which are commonly seen, will be accumulating here as well as here, and curly A and curly B lines will accumulate here. So this is called interstitial edema, and these are diagnostic signs, if you will, on a chest X-ray, suggestive of heart failure. In addition, there will be cardiomegaly. Remember, the heart will be enlarged. So either it's a left ventricle enlargement, a biventricular enlargement where the right ventricle is also enlarged, or all four chamber enlarged, so you will have a heart which will look more globular depending upon the chambers which are involved here. So there will be a cardiomegaly, we call it. Enlargement of the heart. Megaly means big and cardio means heart. So heart is big. Interstitial edema we just talked about, and that's what explains the rales. And then of course S3 gallop is explained because the ventricular diastolic flow is impaired, where ventricles are not able to fill up better. So therefore the S3 gallops occur in the diastole of the cardiac cycle. Other signs which may include that might should be seen are sometimes of course the rales get more prominent, and the interstitial edema starts rising up into the lungs like this, as I'm showing you on the right side of the panel. Patients can develop acute pulmonary edema, APE. And obviously that is a very significant acute exacerbation of the heart failure, where the person should be admitted, sometimes be watched in the ICU or CCU setting as well. Circulation time will be decreased in these patients, remember that. And circulation time phenomenally is less than 15 seconds. You'll be surprised, 15 seconds. But if it is more than 25 seconds, that suggests that there is a delay in circulation time. Therefore, the heart is taking longer time to circulate the same red cell. If you were to tag to come back to the left ventricle, say the point of origin was here, when you're measuring the say a tagged red cell with a radioisotope or whatever you like, and you'll see that it takes more than 25 seconds for it to come back. That is significantly prolonged circulation time, and that suggests heart failure. Okay, hepato-jugular reflux, we call it HJR, and that is when you press on the right upper quadrant of the abdomen. Remember, this is the chest, so this is your abdomen here, and there's liver enlargements called hepatomegaly. And in these patients who have hepatomegaly, regardless whether they have or not, if you press on the right upper quadrant gently, you will be able to elicit the venous distension will only get worse. So the neck veins will actually become more prominent in these patients where you have HJR, or hepato-jugular reflux. Remember the inferior vena cava is connected to the hepatic veins, and inferior vena cava is also connected to the right atrium, therefore to the jugular veins on the top. So it is a transmission of the same pressure impulse, if you will, up into these venous circuits, eventually showing neck vein distension. That's why it's a very common clinical sign, HGR. It's commonly on the boards also. So if they mention that, remember it's a clicker that there is a heart failure going on here. Now, many of these patients, because they have so much of venous distension, so they'll have ankle edema. Okay, so that's a sign of right-sided failure, and or even later on left-sided failure also. Pleural effusions can occur, so you'll have fluid collections, as I am showing in the right side of the panel here. So the fluids will obviously first collect at the bottom. They will have a little C-shaped curve because of the viscosity phenomenon, or the physical nature of the fluid that's accumulating, so the physical characteristics. So there will be a C-shape. They say, the saying is that if you see a small little obliteration of the costophrenic angle, that implies that there is 500 ml of fluid already. Remember that. So that's a cutoff. If you see a smallest amount of pleural effusion on a chest x-ray, you have at least a 500 cc's of fluid that has accumulated there in that particular costophrenic angle. So it's a good chest x-ray sign and should be remembered. Again, these patients will present with fatigue. Remember that. Do not forget that. These are the common symptoms. And dyspnea on exertion. And then you may have paroxysmal nocturnal dyspnea, where patients wake up in the middle of the night, especially around 2 a.m., 3 a.m., 4 a.m., and they'll immediately walk to the window, turn the AC up, turn the fan up, and try to get a better fresh air. And as a result, one may see a great relief. So paroxysmal nocturnal dyspnea is a sine qua non of left ventricular failure. Remember that. It's a sine qua non of left ventricular failure and also of mitral stenosis. So that's on the boards, by the way. And in mitral stenosis, left ventricle doesn't fail, but mitral stenosis obviously compromises on the pulmonary circulation rather impactfully, and therefore causes pulmonary hypertension, increased wedge pressures, increased pulmonary capillary pressures. As a result, paroxysmal nocturnal dyspnea will be manifesting in these individuals, especially when they are in a reclined position or in a laying down position. So the person immediately sits up and starts to feel better, but sometimes he decides to walk, and then he feels better when he goes to the window and takes a fresh breath of air. In a matter of few seconds alone, he will only feel better, or she will only feel better. So that's a typical paroxysmal nocturnal dyspnea history, as somebody would say. Hepatomegaly, I've already told you, and sometimes nocturnal cough can be also minor criteria. You could include that. So these are some of your clinical criteria, clinical diagnostic criteria for heart failure. I've included in this short video. So stay tuned for more. Keep learning and keep sharing with your friends, with your medical students and your colleagues. And again, it's a great brush up for all our practitioners who are going back and teaching their students like me. So I continue to read so I can go back and teach my students still, and that is the whole idea, wanting to educate you on these short videos on MuniMeterHealth, our source of learning, and of course your source of learning, medical education as well as patient education. Thank you again for watching. Until then, until the next video, say goodbye to Dr. Jaitly.